So dear audience, dear chair, let me introduce you to my PhD topics regarding the improvement of acute pancreatitis management. My name is Dorottya Tarján. I'm a gastroenterology resident and a PhD student at the Institute of Pancreatic Diseases. My mission is to improve the management of acute pancreatitis. For that, I have three specific projects. The first one is regarding identifying early predictors for infected necrosis in acute pancreatitis. This is a systematic review and a meta-analysis. My second project is investigating the safety and effectiveness of early cholecystectomy in pregnant women with acute pancreatitis. This is an international survey. And my third one was a perspective article with case reports regarding the severity prediction in acute pancreatitis with a highlight on the artificial intelligence. So let's start with the first project. To understand this topic, first I want to talk a little bit about the background. Among acute pancreatitis, 20% of the patients develop necrotizing pancreatitis. Secondary infection of the necrotic tissue is a severe condition with increased morbidity and mortality, requiring antibiotic treatment or even invasive interventions. However, early predictors allowing the initiation of an early therapy have not been established yet. Therefore, our aim is to identify early predictors for infected necrosis in acute pancreatitis. So, to answer this clinical question, we included patients with necrotizing pancreatitis. For index test, we used any laboratory biomarkers that was compared between the two groups. Our reference test was CT imaging or Gram staining. Our outcome was infection. So we did a systematic search and selection in 3 databases at the end of October in 2022 with the search key as you can see here below. After the full text selection, we got 14 eligible articles. In my first forest plot, you can see the R under the curve of the C-reactive protein. To understand this plot better, first I wanted to talk a little bit more about the AUC. If the AUC is 0.5, it means it's like flipping a coin. We can be 50% sure that our prediction is correct. However, if its value is 1, we can be 100% sure that our prediction is correct. As you can see here, we will be able to conduct a subgroup analysis within different time intervals. Within the first 3 days of admission, as you can see it here, the AUC was only 0.69, which means it has quite a low predictive value, so we couldn't use it in a clinical settings. However, after the first 3 days of admission, investigating at least a 2 weeks period of time, the AUC was 0.88, which is quite good. For the procalcitonin, we got similar results as you can see here. It's also within the first 22 hours, the AUC was only 0.69. However, also investigating a longer period of time, its value increased. It was 0.86. And as you can see here, the white blood cell counts, the AUC within the first 3 days was also quite a low value. So there are some strengths of our meta-analysis, that this is the first one which includes different time intervals and the subgroup analysis. There was no significant heterogeneity in the subgroups, and we used the pre-registered protocol to ensure transparency. However, there are some limitations of our studies. We can only find a small number of observational studies that we can involve, and also the enrolled patients varied in terms of onset of the disease and the severity of the disease. And unfortunately, because of the different thresholds, we couldn't pull the sensitivity and the specificity to give you more results. So we can say that in conclusion that in the first 3 days, the serum measurement of CRP and procalcitonin could be elevated without the presence of the infection. However, if they stay persistently high, antibiotic therapy can be initiated. So as the status of the manuscript, it was published this year, January, at the International Journal of Molecular Sciences. So let's move on to my second project. It's investigating the safety and effectiveness of cholecystectomy in pregnant women with mild acute biliary pancreatitis. This is an international survey, the BURN study. Acute pancreatitis during pregnancy is a rare event, and while most cases are mild, resolving within 2 days, 20% of the cases will be severe. In European countries, the most common cause is cholelithiasis. Acute biliary pancreatitis related to pregnancy has a relatively high recurrence rate of 70% compared to the general population. Early cholecystectomy has multiple benefits as randomized controlled trials, such as the Poncho trial, showed us that it can help us to prevent further hospitalizations because of recurrent acute pancreatitis, cholecystitis, or cholangitis. However, currently, there is no guideline to help us to how to manage our pregnant patients. So therefore, our aim was to investigate the safety and effectiveness of index cholecystectomy in pregnant women. So to answer this clinical question, our two main outcomes was effectiveness, which measured by the readmission rate because of recurrent acute pancreatitis, cholecystitis, and cholangitis. And of course, we wanted to measure the safety of this procedure by investigating fetal mortality, fetal loss, preterm birth, and the need for a neonatal intensive care unit. Our hypothesis was that cholecystectomy is safe and effective during a pregnancy. For the international survey, we received almost 100 patients' data. Currently, we are doing the data cleaning, and we plan to do the final statistical analysis, but we have some preliminary results which I would like to show you. In the first row, you will see the patients who didn't have cholecystectomy during their pregnancy, and in the second row, there are the patients who had their cholecystectomy during their pregnancy. As you can see here, the readmission was 28% in the first group, while there was no readmission in the second group. The most common cause of readmission was recurrent acute pancreatitis. After that followed cholecystitis and cholangitis. We also have some data regarding the safety of this data. As you can see here, the first row is also the patients who didn't have cholecystectomy during their pregnancy, and the second one is who had. And in case of preterm birth and need for neonatal intensive care units, our data was quite similar. In the next table, you can see that the patients who had cholecystectomy after their pregnancy, the intraoperative complication rate and the postoperative complication rate was also similar in the two groups. So in conclusion, we can say that cholecystectomy prevents the recurrence of acute pancreatitis and other biliary complications, and it seems there is no difference in the intra- and postoperative complications during and after pregnancy. Finally, I want to talk about my third project, which was a perspective article with 3 case reports regarding the severity prediction in acute pancreatitis, with a special highlight in the role of the artificial intelligence. The clinical course of acute pancreatitis can be very variable depending on the severity of the disease. Therefore, it is crucial to predict the probability of organ failure to initiate early, adequate treatment. For risk assessment, we have 3 tools. The first one is the use of univariate biomarkers. However, they have low accuracy, and we couldn't use them in a clinical settings. There are multivariate score systems, which are commonly used in everyday practice, such as the Bishop score. And our third new option could be the use of artificial intelligence, such as the easy application, which I wrote 3 case reports showing a mild, a severe, and a moderate case, as you can see here. And it uses multiple continuous variables, and it gives us a risk score between 0 and 1 while explaining the machine learning model. And it can be a tool that we can easily use at the time of admission because it doesn't require all the parameters at the time of the admission, and since it is artificial intelligence, it can continuously improving. This manuscript was published in 2022 December in the Journal of Clinical Medicine. So as an overview of my 3 projects, the first one showed us that persistently high procalcitonin and CRP level can be associated with the presence of infection, and antibiotic therapy may be initiated, and this was published this year, January. My second topic is a international survey investigating the safety and effectiveness of cholecystectomy in pregnant women with acute pancreatitis. I'm currently doing the data cleaning, and I would like to finish this project this summer. And my third project was acute pancreatitis severity prediction with a perspective article with case reports, which was also published. As additional activities, I had the opportunity to work with my wonderful TDK student Máté Verbói, and I have the chance to present my PhD topics at multiple international and national conferences. Dear audience, thank you for your kind attention. Let me finish with a quote: "Research is formalized curiosity." Thank you very much.
Congratulations, 2 papers, and the third one is going out. I mean, this is something. Questions, please. Over there, one.
Congratulations, really, really great. How, regarding the first project, how high were the CRP and PCT levels? Just elevated compared to the normal level, or showed the tendency, or what was meant under that?
Yes, thank you for your excellent questions. Most of our papers didn't give us, unfortunately, an exact data, but more often they compared values above 150 and even more than 200. So it used a really high values. And also for the procalcitonin, the most common used cutoff was 5.
Thank you.
Thank you. I have a question about your third topic. Could you go to the slide where you showed the easy app, the example? Yeah, this one. So my first question is a more general one, the other is specific to this. So in general, how do you define artificial intelligence? So what's your definition of that? And specifically, on the bottom, there's this distribution of the predictions. So this is a single patient, right? You have some probability of severity for that patient. Then where does this distribution come from?
Thank you for your question. I'm not sure I will give you some really nice answer, since I mostly use this application as the clinician, and I'm not one of the informatical person behind this. I would say it's would highlight to show us that based on different prognostic factors, how this can be land in terms of the severity project. So it would like to show us where is the peak of the curve, is wanted to show us where this is lands. And since it's different factors, for example, the blood pressure, that maybe this would move our curve to the closer to the higher risks. And this would like to the prognostic factors which are distributed in this line, in my understanding. And artificial intelligence is the kind of application that can use one of the main curve. This is a machine learning model which can use mathematical models to give us, based on the statistical methods, to give us more information and to find the complex nonlinear relationships between biochemical parameters and clinical outcomes.
So first of all, just to answer your question, because my team is behind this machine learning algorithm, it relies on bootstrapping. So that's what it's coming from. And that's what I wanted to ask. So what is the scientific contribution of this third project? So so the Easy App was published in another article, and in your article, in this article, you did what?
This is just a case report. So in this article, I didn't wrote about all the science behind the Easy application. I just it was the case report article, so I presented 3 cases in it. So that was about it, to show us how the Bishop score and the Easy App can correlate, and maybe some different clinical scenarios when could be an Easy App slightly more helpful to the clinicians.
Thank you. Thank you.
So I'm really not strong behind the science
behind
the Easy application. So it was a case report. I wanted to highlight that during my presentation.
Yeah, in that case, you may should show actually the data instead of the principle. I mean, the principle is fine, but also that your contribution is the data to that one. Another contribution in your second study, I mean, you do this kind of data cleaning. So what does it mean? How do you do that?
It means that the clinicians send us back a lot of data, but sometimes they tied maybe a wrong number. So it's, for example, couldn't be that value for the CRP because just too much zero in it. And I check for this kind of mistakes, and I wrote them an email that maybe this is the correct answer, or could be a reason why maybe this is a false during the human part of the work.
And then what's next? I mean, you get something back.
Yes, and after we do the final statistical analysis, which is quite similar as the analysis I showed here, and we want to do the descriptive analysis also for our patients' parameters, and after that I would like to start to write the article and finish it during the summer, so I hope that this process will be short.
Congratulations. You stated that cholecystectomy is safe in pregnant women. Is there any difference between the 3 trimesters? Because I consider that you should take into account different risk factors in a pregnant woman in the first, the second, or the third trimester.
Yes, thank you for your excellent questions. You are absolutely right. The most common recommended period is the second trimester. This is when we should perform the surgery. And also I would like to highlight that it's really also an important aspect that it should be a center for this kind of surgeries, and there is also a need for a neonatal intensive care unit to be behind the surgery, and also the presence of the neonatologist is needed there.
Which was the most important factor when you have to decide if a pregnant woman in the third trimester should be operated or you should wait for after delivery to be operated?
Thank you. So I would say that currently the guidelines advise us to wait, because they could be so close to the end of the pregnancy that it doesn't really need any more interventions, and we could wait till the end of the pregnancy. However, there was a current meta-analysis published which finds no difference in the trimesters regarding the safety of the surgery. So it's really up to the clinicians to decide in every case.
Thank you, Dorka, for your presentation. You said that the current guidelines said that. I'm curious that how your preliminary results compare with the existing literature. What do you saw there, and how can you compare them?
Thank you for your questions. So we found that the surgery during pregnancy appears safe, and also in the current recommendations also found that surgery is safe. And even for biliary complications like colic occur pain, they recommend to have an elective surgery because there was a lower rate of preterm births compared to the patients who only had conservative management. And also for cholecystitis, they also recommend to go under surgery during pregnancy.
Congratulations. So one question regarding the easy app. My question would be actually regarding how are you satisfied with this app in your clinical practice? Does it work very well for you? Are you using it regularly? And also if you can elaborate a little bit about the case when it's probably better than BSAP score.
Thank you for your questions. So we use it in our everyday life, and I think it's currently quite similar like the BSAP score, but in case where there is a really fulminant case, it can give us a better estimation compared to the BSAP score, because it's more involved clinical parameters like the blood pressure and the heart rate, more like the NEWS score. So it can help us to differentiate in that cases early on.
Nice data, nice presentation. So I've got 2 questions. The first is, if we talk about surgery after pancreatitis, what is in your hands a good time? What is your indication or time definition after acute pancreatitis? When do you go for surgery?
So in cases when the acute pancreatitis happens during the first trimester, I would wait for the second trimester and then I would operate the patients. And in case they are only in the second trimester, I would schedule their surgery early on. Of course, because this is mild cases, it could be really close to the time of the admission because of the acute pancreatitis. And if they are in the end of their pregnancy, I would wait still after birth.
And from the perspective of pancreatitis, we cannot operate in the acute phase of pancreatitis. So we are waiting after pancreatitis. How long do you wait? When do you send us your patient for surgery?
So we would wait 1 week or 2 weeks, and we send them after that for the surgery.
And which kind of parameter are you using for this for decision?
We can use ultrasound to check if there is a local complication there, and there is also the CRP levels that we are used to check, and the amylase lipase level needs to be in the normal range as well.
Good. And coming back to this nice results, we have a 100% positivity in if you go one back, please. You have no readmission in the 11 patients getting a surgery after pancreatitis, and you have 1/4 of patients getting readmitted. So you think it's a good results. Do you think it's still a basis for performing prospective trial?
Yes.
Or it's forbidden because these are convincing. So is it? Do we have a right to do a prospective randomized trial to figure out the real results? So we have 11 patients, again 39. Can be not. So do you think we have still the right to do a prospective randomized trial? And this is possible in pregnant patients?
I think with pregnant patients we couldn't carry on a randomized trials because we couldn't give them really a whole overview of the procedure and the risk and benefits, and we couldn't really say them that they had to, based on our selection, go one way or another. So I think this kind of population we couldn't do a randomized trial. And one of the, I think, the psychological factor is a really strong cause of it, and because there is like 2 lives at the rope for this kind of procedures.
Yeah. Good answer.
Yeah, you mentioned you are using in your daily practice this different scoring system to assess the severity of acute pancreatitis. What is your practice? How frequently are you repeating like the Easy app? Whenever you have a new data, you are just inputting and you are changing your prediction, or does it make sense to repeat? How many times do you need to repeat until you are getting close to the final outcome of that given patient?
We just only do it once at the time of the admission, and then we usually so we have to do at the time of admission a full laboratory test for the patient, so we will be able to fulfill this test as we work as a research center for also the validation for the Easy app. So basically we perform it every patient at the time of admission, but after we don't repeat this exam.
I believe it would make some sense to check the dynamism of the changes, because also might have some predictive values, how the CRP, PCT values are increasing, how rapidly are increasing, how rapidly are plateauing or going back to the normal. So that's why it might make sense to check the dynamism of the changes.
Yeah, so this is a team, I think, and then the team decides on this, and then I'm sure that they will actually follow this. Yes, please.
Yeah, thank you for your presentation. I have a question regarding to the board study. So how would you handle cases like here when you have patients with cholangitis as well?
Thank you for your question. In the survey we got a lot of answers where while patients had a mild biliary pancreatitis, they also had a cholangitis and a cholecystitis. So we plan to do another subgroup analysis in these patients who, at the time of the admission, because of the mild acute pancreatitis, also have another condition, and we also wanted to evaluate these outcomes in these cases. So in this first part of the analysis will be patients who had only had mild biliary pancreatitis, and in the second part of our analysis will be patients who also got cholecystitis, cholangitis, or they got a moderate acute pancreatitis and they had their surgery at a later time during their pregnancy or after their pregnancy.